and I'm grateful to the organizers for giving me a chance. And very good afternoon to my dear friend Kirti Punamia and all other panelists. So I will show two cases which have been recorded uh, within this month. Can I have my slides? So this is a 84-year-old gentleman who I did angioplasty in 2014 after rotational atherectomy to LAD and put one stent to LAD. And there was also a stent in the LCX in the middle part. And the patient was fine, and he was an optimum medical therapy and used to come for follow-up once in a year. But recently, he was having frequent nocturnal angina, and he came to our hospital. He is a diabetic, and his ECG from the initial period had left bundle branch block pattern, and ejection fraction was around 46%. So we did an angiogram, and this is the angiogram. So initially we thought that he has his previous stent, both the stents were good, and initially we thought that there is a very nasty disease and long disease in circumflex, thoroughly calcified. So I thought that we should go increasing the medical therapy more and see what happens. But his pain gradually increased, and he came to me and said, look, I can't tolerate this pain every night, so do something for me. So I thought I would be doing an angioplasty. But as you have seen the LCX, it needed a lot of, it is a very long disease. You need at least 3-4 stents, and you have to make a metal jacket from the ostium to the, to one of the OMs. And so we thought that we would go only with rotational atherectomy and perhaps with some part of the stent which is not affected by ISR. We would put a DEB there, and we would put another stent this time. But it is a very tortuous LCX, and we thought that in a tortuous LCX it would be better to have an undersized bar, as we always do that, and planned a one bar strategy with lithotripsy for the proximal part. So with that in mind, this is the larger view, and you can see that there is a very tortuous LCX, and also in the distal part there is a significant lesion, but somehow the stent in between is not much affected. So I started barring with a 1.5 bar. So this is the 1.5 bar. Very slowly I went through the tortuosity down to the stent itself, and then after the rotational atherectomy is done, I put a semi-compliant balloon and dilated the distal part of the vessel with the balloon at 18 atmosphere. The balloon opened to some extent, but there are some areas where the balloon has not given a good result. So I put a scoring balloon, it's a 2 into 10 millimeter, and went in up to 20-24 atmosphere. And after that, you can see that there is some amount of dissection in the lower part of the artery, and we thought that we could put a drug-eluting stent there. And this is the drug-eluting stent from the in the old stent. We put a drug-eluting stent, and after putting the drug-eluting stent, we dilated with the NC balloon 2.5 into 12 and went up to 28 atmosphere with a good result. There was a significant lesion in the last OM1, but as it is less than 1.5, so we did not do anything there. So after doing the drug-eluting balloon, doing the drug-eluting stent in the distal part of the stent, I put a IPL catheter, which is 3.5 into 12, and gradually shocks were given, and the vessel opened nicely. So I put a drug-eluting balloon in the stent part, the original stent part, at 10 atmosphere for 1 minute, and I put a synergy 3.5 into 32 at 12 atmosphere, and I dilated with a 3.5 into 12 at 20 atmosphere with a good result, with all the vessels intact, and the patient is doing well. So this is my first case. I think before going into the second case, we can have some discussions if the panelists allow. Otherwise, I can go to the second case and we can have all this.
Yeah, so Dr. Shuvanan, I think we can have a comment from Dr. Fazila and Dr. Mirzaman. So can you say?
I cannot hear you, Aftab. Can you be a little louder, please?
So can you hear me?
Yeah, I can hear you.
So that was such a brilliant case, so masterfully done. I mean, hats off to you. I'm tackling that tortuous LCX with a rota just goes to show that you were very well in control of the rota to take it into that tortuous vessel. But my question is, do you think IVL was essential later on, or could you not have done a good enough job after the rota with a cutting balloon, or maybe even go up to high pressures with a scoring balloon?
Madam, thank you very much for your kind words, but I thought basically this was a very tortuous vessel, and I have a very not a very pleasant experience with cutting balloons after rota in a very tortuous LCX, because patients, cutting balloons and scoring balloons, they go according to the they are fixed blades and fixed cutters, so they produce more complications and dissections and perforations. I have seen more rather than rather than IVL balloons. And particularly I have done 4 cases of IVL in tortuous LCX and tortuous RCA. In each and every case, the balloon could line the tortuosity nicely, where the cutting balloon and scoring balloon cannot. This is my personal experience. So I thought that I would need a better thing to open the artery nicely, because the artery is 3.5, 3.75. I used it 1.5 bar because of the fact that in a very tortuous vessel, I always undersize the bar to some extent. That's why I took a smaller bar. And for that, for a larger vessel, I thought that IVL would be better than a scoring balloon or a cutting balloon.
Thank you, Dr. Roy. I am Professor Mir Jamal for brilliant case. But my question is that in a previously stented vessel with heavily calcification, you have done rota. How often you do rota in a stented vessel previously with this type of calcification?
Yeah, but we have a good amount of data which will be published, we have given for publications in, in-stent restenosis and DEB, where we saw that the DEB is better in cases where there is a focal restenosis or there is, less restenosis, less amount of neo-atherosclerosis or neo-intimal proliferation. In such cases, DEB is a better modus of operation than DES, I believe. That is the reason when I saw that my stent is not having a lot of ISR, and I crossed my stent with rota and by a lot of devices, And I thought that there would be some amount of injury to the intima of the vessel there. So I thought that it can produce, it can give rise to ISR. That's why I put a DEB there in the stent portion, not in other portions. In other portions, there are a lot of calcification, and in calcification, DEB doesn't work. So in the stent portion, there was not much of calcification, and the stent was perfect. So I thought a DEB would be better.
Dr. Roy, another question would be that I don't see any imaging that's been done. Would you suggest that an imaging would have been something that would be almost essential, because given the fact that...
Absolutely, Aftab, I admit that imaging could have been done, but you know, this was a lengthy case, and this gentleman is 84 years old, LV dysfunction, and I could have done I was there, but I thought that I finished the job and come out, and as I saw that technique, angiographically it looked good, so I didn't do the imaging. But if this is not I know that before, you know, giving this case
given the osteal circumflex disease, given the osteal circumflex disease, I think the concern is always whether the disease is extending back into the left main, and this is a left dominant circulation. I mean, probably a planning would have been much better.
Absolutely right. But the left main is very small. I mean, short here. It is absolutely a short left main. So I thought that probably I have seen there after 2 angiograms, either in the one in the beginning, and I kept him on medications for a few months and few days, and second one during the PCI. So there was no damping, nothing, so I could not do. Yes, I admit that one imaging would have been better.
Wonderful.
But I
think you can move on to the second case, sir.
Okay.
Dr. Roy?
Yes, I'm going to the second case.
Yeah.
This is another case. I think the patient is 77-year-old. He has a diabetes mellitus, again hypertensive, ejection fraction is 60%. Came with gradually worsening angina for the last 1 month, and he has a stable ischemic heart disease and on OMT, and he went to another hospital and got an angiogram there. This is angiography. So in the angiogram, you can see that there is a significant left main disease with Medina's 111, and the right side is normal, and this is very severely calcified. So we are getting another severely calcified vessel, left main disease with Medina 111, and the patient, as he is 77-year-old, a gentleman, and he denies surgery. So he is not for surgery. So we thought that we would go for angioplasty in his case with 2-stent strategy and nanocrush after plaque modification by rotational atherectomy. So this is the angiography, and you can see the calcium, which is seen in the angiographically seen, and it signifies severe calcified disease, and this is a tram track calcification. And we started with a 1.5 bar in the LAD and LCX. I am showing you the LAD. So after doing the LAD, and this is the LCX, which after the LAD and LCX we did both the branches, and this is the IVUS image. Then we did an IVUS. This is the IVUS image, and you see that after the rotational atherectomy, there is significant cut, and you can see the reverberation on the LCX also by rota, and also there is LCX ostium is around there is significant, calcium is cut, but still there is stenosis, and so we used a scoring balloon 3 into 10 millimeter at 18 to 20 atmosphere in the LAD to LMCA, then to the LMCA itself.
Dr. Roy, we have 5 minutes, if you could just finish off.
Then we did scoring balloon in the LCX only. And then we took 1 3 into 12 millimeter balloon in the LED and synergy 3.5 into 20 and positioned the stent by inflating the balloon and pulling the stent towards the LCX, pulling the stent towards the LMCA to the inflated balloon and deployed at 14 atmosphere. Then I pulled the stent balloon inside and inflated at 20 atmosphere, then did a first kiss at 12 to 14 atmosphere. This is the first kiss. After the first kiss, I put a DS 3 into 38 millimeter at 14 atmosphere from the LMCA to LED, did a pot with 4 into 8 millimeter balloon, and after pot we have a picture like this. Then I crossed into the LCX transstart and firstly I inflated the 1.25 balloon, then final kissing was done with a 3 into 12 millimeter in LED and NC 3.5 into 12 at LCX at 14 to 18 atmosphere. This is the IBUS imaging post-stenting, and you see that the sizes are fine and every ostium is rounded. And then we did a depot with 4.5 millimeter balloon at 6 atmosphere, at 16 atmosphere, and this is the final result. Final result. So conclusion is, calcification is the major cause of under-deployment of the stents, and calcification is often underdiagnosed in the angiography. Though in our case we could see it very often because it's a very severe calcification, needs imaging to assess. In the first case we could not do it, but in the second case we did imaging. In most cases intravascular imaging is difficult to perform because before rotational atherectomy or before planning your sometimes the catheter doesn't go. Angiographic suspicion would lead to device selection. Either balloon could cross, try with the balloon at nominal or high pressure. Either balloon doesn't open or balloon doesn't cross, then you have to take some device like rotational atherectomy, larger vessel. If it is 3.75, 4 millimeter vessel, you require an additional scoring cutting balloon or an IVL. Many tools and skills are now necessary for successful treatment and optimizing results for complex coronary PCI. Plaque modification for calcified lesions using atherectomy technique will facilitate stent delivery and optimal stent expansion and long-term outcomes when coupled with imaging. Thank you very much for patient.